in the keynote address. So I invite Dr. Bejoy Thomas, Professor, Department of Imaging Sciences in Sri Chitra Tirunal Institute of Medical Sciences and Technology. Dr. Bejoy has more than 200 international publications, 8 book chapters, and 2 patents to his credit. He has received numerous national and international awards and has secured a place in Stanford's top 2% global scientists. His area of interest is advanced neuroimaging. So over to you, Dr. Bejoy.
Thank you, KSOS and Dr. Bindu, for this invitation. I have the maximum time in this session, but 15 minutes is not sufficient to see everything in neuro-ophthalmology as far as imaging is concerned. So we will stick to two things. One is vision loss as well as ophthalmoplegia. So these are my disclosures and also disclaimer that it's not a complete review. So we will see the first case. We'll see cases. So this is a 53-year-old female presenting with acute vision loss on the left side. And you can see this is a T2 weighted scan where that the whatever is inflamed or a fluid will be bright. You can see there is some collection here on the left eye, the choroidal subretinal level. And also in contrast, when you give contrast, you can see that it is actually enhancing. While we are pondering the diagnosis, we will see another case. This is a case, middle-aged female came to us with operated twice for retinal angiomas. It's an old case. I don't think for retinal angiomas anybody will do surgery nowadays. Now she has actually come with a complete vision loss with the thysis bulbae on the right side. Again, how you actually image these, we will discuss at the end of the talk. So we move on to the third case. This is a middle-aged female with a visual blurring and headache. So whenever a patient comes with acute onset or a relative acute onset visual blurring and headache, we can actually go directly for an MRI because that is the gold standard. Again, one thing I would like to highlight is that there is a tendency that to do initially a CT scan followed by an MRI if needed. And in the era of very reduced affordable cost of MRI, I think there is no role for CT scans except in trauma or when you are actually, there is a contraindication for MRI or when there is, we are suspecting an intraocular or intraorbital or intracranial foreign body. So you have to directly go for an MRI, and the CT, most of the time it is only adding to radiation to the lens as well as the brain. Especially in children, you should avoid this, and probably getting future patients for yourself by inducing radiation-induced cataract as well. So this is a case when you see first itself, you can see the perioptic nerve sheath fluid is actually prominent, and also there is a horizontal buckling of the optic nerve. If you are very careful, you can see there is a posterior scleral flattening, and which you have already diagnosed this with the optic nerve, the fundus examination as a raised ICP features. Again, for us, we can't actually see through an indirect ophthalmoscope. What we can see is actually the globe as such. You can see there is a posterior scleral flattening, and again, if you do the contrast, you can see that the optic nerve head is actually bulging in, and it's also showing enhancement. So this is the optic nerve on the horizontal, the coronal section, that is from superior to inferior. If you cut that, what you call that equivalent of an AP section, what we call as a coronal section, you can see the optic nerve fluid is, there is a significant perioptic nerve CSF fluid there, and it is prominent. We will discuss about the dimensions later. And again, you have to carefully look at the sagittal images. You can see in addition to the horizontal buckling, there is also a vertical buckling. So, and if you see this, you have to immediately do a venography and see that the left transverse sinus is relatively hypoplastic and there is relative narrowing of the transverse sigmoid junction, and the right transverse sigmoid, the distal transverse sigmoid junction also there is narrowing. So this is a case of raised intracranial pressure, idiopathic intracranial hypertension. And when you see this, what next is actually immediately you will actually put the patient on Diamox. That is a good thing to prevent any visual loss, because they can go for a very early visual loss if not treated properly. And one of the newer treatments is actually to measure the pressure gradient across, and if it is there are more than 10 millimeters of pressure gradient, 10 millimeters of water pressure gradient, and you can actually stent this, and the patient can have a significantly reduced intracranial pressure. So this is one of the things. But venous stenting is also not a very easy thing to do, because the antiplatelets may not work as well as in the intra-arterial system. But there are many cases where the stenting, the dual antiplatelets are treated for 6 months and followed by single antiplatelet. Patient will have a very good prognosis. So another very interesting thing is that as soon as you see this on an MRI, you will not go and do stenting, because raised ICP itself can produce a narrowing, especially the posterior part of the superior sagittal sinus, side to side flattening, as well as narrowing here. So you have to see that whether this is a physiological narrowing, or it's actually, this narrowing is actually whether the chicken or egg situation. So you have to make the pressure measurement through the transvenous microcatheter, and then only you can think of. Otherwise, the treatment is actually doing a CSF shunting, either thecoperitoneal shunting, as well as continuing with the medical management. So we know that the optic nerve, I don't have to teach you that the parts of the optic nerve, and this is where we are actually looking at when the patient comes with vision loss. We talked about this. Most of the adult patients after the age of 2.5 years, the optic nerve size may be relatively constant. The total diameter of the optic nerve is around the maximum 5.5 millimeters, and the optic nerve, including the sheath, and the optic nerve as such will be maximum 3 millimeters. So in Indian population, we have found that around 4.5 and 2.5 to 3 will be the actual diameters. And intracranial hypotension, you can see the optic nerve fluid is actually getting drained out, and you can see it is not there, whereas in raised intracranial pressure, you can see that this fluid, perioptic nerve fluid, is actually increasing. So there are various causes of optic neuritis. Again, I wanted to highlight this because this is not the way the neurologists and the neurophthalmologists manage these cases may be slightly different. So the evaluation algorithm, as soon as you see the optic neuritis, when the patient presents with the visual loss, with the difficulty, painful movement of the eye, or a color vision loss, you will start actually doing this fundus examination, your optical coherence tomography, and you start the IV methylprednisolone. So that is not the way actually it should be done as far as the complete evaluation is concerned. Because optic neuritis is a medical emergency, and immediate blood investigations have to be sent, including the NMO-MOG antibodies, as well as the other antibodies which, if it is feasible, and also the routine blood investigations. Immediately after that, an MRI has to be done. An MRI has to do not only the orbit, but also the brain as well as the spinal cord. And we have seen that the recurring optic neuritis, most of the time you have to prevent that recurrence. That is why we are actually making a difference, because with every optic neuritis, the vision is actually deteriorating and it may not come back to the normal. And after MRI only you should do an LP, and you have to make sure that there is no raised ICP which is causing this. Secondly, after LP, if you do MRI, there will be significant congestion, and because of the intracranial hypertension which is produced by even removal of even 10 ml of CSF, and which will actually confound your diagnosis of an contrast enhancement. After that, you can start your methylprednisolone. So it has to be done on an emergent basis, and all these things should be done. And why we should do an MRI of the brain in the first instance itself, because you can see sometimes Dawson's fingers, sometimes there can be, patient may be completely clinically asymptomatic for this neurological evaluation is concerned, but that is called the clinically isolated syndrome, except for that optic neuritis. But you can see that there can be a radiological isolated syndrome also, and then when you can see that these radiological findings, and then you can have no corresponding clinical features. And with the 2017 and the latest very recent the upgrades of MR classification, MR is actually, the MS classification, MR is actually coming to the forefront. If you have more than one lesion in the supratentorial, one in the infratentorial with the myelin the OCB is positive in the CSF, that itself is diagnostic of MS. Why we want to diagnose in the first instance itself, and this is a very graphical representation of where MS is actually producing these abnormalities. Mostly it starts in the one eye, and it will be more in the anterior part of the optic nerve. And you can see in the spinal cord also, you have to very carefully see very short segment spinal cord involvement, and also there can be peripheral lesions which are very small, which are eccentrically located, and the callosocceptal margin may be involved. This is called the dot dash sign or the Morse code sign, and these are very subtle things, and if you don't do a very high resolution scan, you will miss it, and also you can see the Dawson's fingers. So why it is very important that you can actually start with the present classification of the McDonald's criteria with MRI as well as the clinical as well as CSF examination, and you can start a disease modifying agent. Now there are disease modifying agents like the newer monoclonal antibodies, whereas the patient's outcome can be much significantly better rather than treating them again and again with steroids every 6 months. So this is the spinal cord involvement. So the first instance is the short segment, less than 2.5 vertebral body segment cord involvement, and these are really important, and this is how you can actually make a difference. Why? I know previous speakers have actually highlighted the neuromyelitis optica as well as MOGAD, and this is a very severe demyelination, which is a necrotizing demyelination. It has to be very aggressively treated, not only with steroids, also with the plasma exchange and IVIG most of the time, and also very aggressive supplementary treatment should be done. We can see that the circumventricular organ will be involved, the periaqueductal regions. If you are doing a routine imaging with the 10 millimeter sections, you are going to miss this, and usually there may not be much of a cortical or subcortical involvement. It can be atypical ventricular involvement, not typical Dawson's fingers, and also you can see very long segment cord involvement. Here bilateral optic nerve as well as the chiasm can be involved, and it will produce, it can even present with the persistent vomiting, and because it is involving the area prostrema regions, you can see this. In this case, you can see again you have to very carefully look at the FLAIR images, these areas, the area prostrema, that's why the patient is having a recurrent vomiting or sometimes intractable hiccups or cough. And this is how it looks like. It is a long segment involvement, and another reason why we should do not directly start steroids without an MRI is because some of the LETM, the longitudinal extensive transverse myelitis cases, may be due to a dural fistula. If you give a single dose of steroids, they are not going to improve even with the embolization therapy in the rest of their life. So that usually will not present luckily with optic neuritis. So most of the time it will present to a neurologist or a neurosurgeon. Here again the circumventricular organs are involved, long segment is involved. Very aggressive treatment is needed because if they recur, it will be usually very devastating. And also presence with the bright spotty lesion. I will not go into the entire radiology of this. Again, you can see that the perioptic nerve in this particular case, there is inflammation in the perioptic nerve lesion. You can see this fat stranding of the optic, the orbital fat. This is what we call the dirty fat sign, and you can see in this case, in these cases, conus may be more involved. If you see this dirty fat sign, it is more suggestive of a MOGAD. So there are ways in which you can actually, with imaging itself, we can actually differentiate. This is a 17-year-old patient presented with the vision loss in the right eye followed by the left eye. Again, you can see the right optic nerve is thickened. Initially it was enhancing, it was diagnosed in optic neuritis. Later you can see we have to do a spectroscopy also. You see the lactate there, and the patient, there was a very sudden, rapid progression of the vision loss, and this turned out to be Leber's optic neuropathy, and sometimes Leber's usually present with optic atrophy, but in the acute phases they can even present as an optic neuritis like presentation even with a contrast enhancement. Now the chiasm tracks, because of the lack of time I will actually quickly go through that. We can also look at all these things. This is a graphical representation of how the optic pathway is running. What we can see that the anterior optic pathways can be diagnosed, been seen very well with the T1 and T2 weighted images, where the optic radiation right from that lateral geniculate body to the Mayer's loop can be seen with newer advanced sequences like SAA, because myelin is showing a susceptibility there. And you can see this even your routine cases, you can see the lateral geniculate body, but how many of us are actually giving a look into these areas where we are actually having an acute vision loss. So coming to that pituitary lesions, or this is a Rathke's cleft cyst,
and which is producing the chiasm in the center. The classical teaching is that it produces bitemporal hemianopia, and we have never seen a single case where it's true bitemporal, because it will be always asymmetric. This is what happens. Normally the pituitary gland can be 88% of the time it is centrally located, the chiasm, but there can be prefixed or a postfixed chiasm. So you are exact because the pituitary lesions don't read in ophthalmology, neuroophthalmology textbooks. This is what happens, and your diagnosis most of the time will not be very accurate as far as bitemporal hemianopia is concerned. Then we have to do epilepsy surgeries, and we have to make sure that they will not produce, the surgery will not produce the after anterior temporal lobectomy should not produce a quadrant anopia. This is what the Mayer's loop is there. This is how that resection will produce a superior quadrant anopia. So we have to do advanced sequences like diffusion tensor imaging, can map this from the lateral geniculate body to the Mayer's loop to the optic radiation, and we can actually show the surgeon that this is, we have actually published some time back. Now with the SWA sequence which I have shown that myelin is producing susceptibility, you can actually track the tract, and the surgeon can limit anterior to this. So the cortical lesions, cortical blindness, we can do functional imaging, especially mapping these visual areas, visual association areas. They are mostly used for only research, and this is the last few cases. This is a 56-year-old male, diabetic hypertensive with a sudden third nerve palsy. You can see if you are not careful and do thin sections, you can miss this, and diffusion, you can see the third nerve nucleus is actually infarcted. So the perforators infarctions can happen even in the nucleus, and this is a nuclear involvement. More commonly you will see that the third nerve palsy may be due to mechanical compression or a demyelination of the third nerve itself. This is actually the third nerve, and in this case the patient present with a partial third nerve palsy. You can see this is the posterior communicating artery, and the posterior communicating artery is actually shifting the third nerve and partially compressing it. That's why patient present with the partial third nerve palsy. Compared to this case presented with the complete third nerve palsy, which is due to mechanical compression, unlike in diabetes, and you can see the pupil is involved, and this is due to a parapicum aneurysm, which is again compressing the third nerve. This is a very interesting case. One auto driver, I don't know whether I can take one more minute. So one auto driver, the auto rickshaws, if you are not careful, auto rickshaws have projecting needles all over. You can see they have a very sharp objects as a wheel cup. And also in this particular case, auto driver was actually cleaning his auto in the morning, and there was a very sharp needle-like metallic thing from the rear view mirror. He was actually cleaning, and he suddenly got up and hit something, and there was a little bit of blood. Immediately noticed that there was a drooping of eye, and when he was actually brought to ophthalmology and he was a third nerve palsy, he was sent to us for imaging. After CT scan, we saw, he thought that initially it was considered as a blunt injury with some injury there, but what is actually gone, we have after doing the CT, we found that there was a defect in the squamous temporal bone. When we have done the MRI, after ruling out that there was no metallic objects, there was a very sharp needle which has actually gone inside and came back when the patient was flipping. So this was not it was a sharp injury which has actually gone and actually hit. This is where the third nerve is in the wall of the superior part of the cavernous sinus. It has actually gone and hit that the third nerve and came back. This is the needle track, and the patient didn't know that it was actually head injury. So luckily it has actually not injured the cavernous carotid artery and not produced a pseudoaneurysm or a CCF. And this is the thyroid ophthalmopathy. For the benefit of the postgraduates, this the mnemonics is that inferior rectus, medial rectus and superior rectus, the way in which actually it is involved. The inferior rectus will be the maximum involved, so the mnemonic is I am slow, and sometimes superior rectus can also be first involved, so then it's called sim slow. And this is carotid cavernous fistula. We have actually seen the different subtypes, and we can do very easily, you can diagnose with an arterialization of the superior ophthalmic vein, and we can do the embolization as previously mentioned. This is a very gratifying thing for interventional radiologists. Only interventional neuroradiologists can treat this. There's no surgery can be done, no medical treatment can cure the patient. So this is a last case. The 40-year-old doctor presented with altered sensorium and complained of something crawling inside her eye. She was also, because she had an altered sensorium, this was an old case. You can see that there was some hyperintensity in the cerebellum, This is when, this was in 2007, when we had the SWA sequence as a new sequence, so we tried to do this. You can see some hypo-intensities there, then very subtle enhancement, we didn't know what it is. Again, if you see that there are hypo-intensities there, susceptibility blooming there, and this is what she, after 2 weeks, there is further increase. Because she was seeing this, there was the vitrectomy was done. This is what they removed, and this is, you can see, this was a case of angiostrangulus condensis infection. What we saw in the brain is actually lava migration tracts. So this was luckily diagnosed early, and when you are actually, this is not commonly reported from Kerala, but there are reports from Kottayam, and you can see that these, especially when you are actually, when these snails are infesting your horticulture garden, you should not actually eat the raw vegetables. So that's what this patient did. And then coming back to our last, the first few cases, this case had a enhancing in the choroid, and this turned out to be a metastasis. You can see a large mass in the breast. So usually we don't see diagnosed breast carcinoma like this. Will be very, very subtle, and this case, even when that there are axillary lymph nodes and mediastinal lymph nodes and metastasis. So this is you have to be very aware that when you see these cases, it has to be appropriately imaged. So melanoma metastasis, you can see that can be diagnosed, even MRI. T1, it is bright, and in T2 and susceptibility will bloom. And the second operated retinal angioma case, this when we did the spine imaging, you can see multiple hemangiomas, and this is a von Hippel-Lindau syndrome. You have to also screen the abdomen for pancreatic liver cysts and vessel renal carcinomas. To conclude, clinical diagnosis is the key, and I think you should do appropriate imaging, complete imaging, so that we can actually help the patient, especially for acute optic neuritis. You should not treat it as an isolated syndrome, isolated disease, but it can be a real syndrome. It can be treated, and you can prevent that second recurrence. Thank you very much.